Okay. All right, let's start this webinar. As people keep joining, the Cyber Infrastructure Specialty Group of the American Association of Geographers welcomes you to our webinar on COVID-19. These are extraordinary times which demand extraordinary response from the scientific community. Today, we have the privilege of hearing from three presenters and their outstanding research efforts towards this pandemic. Before we begin, I'd like to announce a few news items regarding our specialty group. So the first one being that the Cyber Infrastructure Specialty Group has a new website. It's www.aag-cisg.org. Please check it out. Our student directors have spent great effort to migrate the website to its new and hopefully permanent place. I also posted the link in the Q&A of this webinar. So if you want to just copy and paste it from there, feel free to do so. Then we are hosting the Robert Raskin Student Paper Competition virtually at AAG 2021, which takes place from April 7 to April 11, 2021. So please, if you have students or if you are a student interested in cyber infrastructure, consider submitting your presentation to our competition. And lastly, the Cyber Infrastructure Specialty Group, as it does every year, wants to publish a newsletter and is looking for news items, news from the community. So if you have, were awarded a grant or you published some groundbreaking research that you'd like to share, the newsletter will be available to all the members of our specialty group, which is more than 100 people. So this is an excellent venue to promote your work if you feel like sharing it with the community. All right, so now I will stop talking and we'll hand it over to our first speaker. Our first speaker today is Dr. Song Gao. He's from the Spatial Data Science Lab at the University of Wisconsin-Madison. And the title of his talk is Multiscale Geospatial Modeling of COVID-19 Spread with Human Mobility Flow Data. Take it away, Song.
Okay, yeah, thank you very much, Alex, for inviting me. Also, thanks everyone for participating. And today, I'm just going to introduce several works we have been doing in the past half a year. And I hope that that can maybe give you some insights, either geographer or geoscientist, what we are doing. First of all, I think one phenomenon most people observe was that during this COVID-19, a lot of companies, organizations, they are providing tremendous open data to support academic researches. Specifically, we are interested in the human mobility data to understand where and when people travel and how the COVID-19 pandemic has impacted such human behaviors. And for instance, like Google mobility reports provide aggregated status and to understand 6 types of the foot traffic visits, and some other companies such as Yeon, they provide the social distancing dashboard to understand county level behavior changes. And there are many other data providers also provide the such both aggregated and then individual level mobility data sets. For instance, here is one individual level trajectory tracking data, which actually review how the summer rally, the motor rally in South Dakota, and further, where people come from and how they actually move around the nation afterwards. There was one non-peer review article actually talk about potentially there are about 20% of the spread might be linking to this event. But again, here just give you a sense that by incorporating such a tremendous, large scale human mobility data, which may provide some insights. And for our lab, we respond in early spring, and we collaborate with different data providers, and we do the data processing and provide a web-based dashboard to understand the national level human mobility changes, and then also further support different applications that use such data and to do the research. So this is just the one animation what I show in several scenarios, and here just to show you how the mobility changes in the March after the declaration of the national emergency in the United States, and the color in red means that there is increased mobility on that specific day compared with the normal in February, and versus the blue means that reduced mobility for county on that day. And at the local level, we also provide such a mobility or social distancing dashboard to inform public health and then the decision making. We look at three specific mobility index. The first one, also the most important one, is the so-called close contact index. So for two mobile phone devices, we can measure within a certain time window and how close they are, and then we can give a summary statistics about the mean contact of a region based on the mobile phone tracking, and then we can provide such spatial and temporal visualization to support, such as our campus reopening and keep tracking what's going on. That's the close contact index, and also support the modeling effort. The second is the home's dwell time. That is, for those devices, if they completely at home, if it's stationary, and then we can measure the home dwell time, and that also change over time. The last one is the mobility index, which is based on the travel distance. So which means that based on different trips of individuals, and we can measure what are their travel distances, and then get some maybe mean or median and for a geography unit, and then we can measure the temporal changes as well. So this is the local mobility dashboard. So utilizing the mobility data, and we can further do several analysis. In the following, I will show you two things our lab did. The first thing is we just do a very simple earlier exploration about the association of the mobility changes with the rate of the COVID-19 cases. So which means that on one hand, we are measuring how the mobility changes in late March and early April, and how the stay-at-home orders have impacted the human mobility changes. And we were looking at the travel distance and then the home dwell time. And what we found was that, as you can imagine, with a more steep growth rate of the COVID-19 cases, and you will assume that much faster response in those states. So generally speaking, there were on average about 0.5 Pearson correlation between the mobility changes and then the COVID-19 infection rate. And if we look at the one specific measure in epidemiology, that is doubling time, which means that the number of days that need to taken to double the infection cases. Here in the graph, the green shows that the state level statistics before the stay-at-home order, and then the blue show the after order doubling time, and this is the density plot. Although the doubling time change vary state by state, but overall you can see that the two peaks are definitely different. And then after the stay-at-home order implemented, and the delay of the doubling time mean that that reduce transmission of the virus, which indicates that, yeah, the policy actually indeed worked. So this work was also reported by CNN Health. And the second thing is, in order to do the modeling, and one thing we need is actually to get the origin to destination flow matrix. So as you can see in this graph, before the pandemic, during the spring, that's the spring travel season, we can see a lot of inter-county or interstate movement around the nation. However, during the lockdown, you can see much fewer long distance travels, and the whole spatial interaction pattern has changed. So this is why we need such open data to support either modeling or to further understand the OD flow patterns. So this is why our lab in collaborate with the SafeGraph, which is a mobile phone data provider. We provided such an open data set and keep updates on GitHub to support other research as well. So this is a county level, and this is a sensor tract to sensor tract level because the data file is too large. I just show you one state, but you can definitely, if you want to analyze the over 220,000, tract to tract interaction, you can also download the much larger file. So this is the data. And then most of the existing data is only about the samples. So this is why we made an additional effort to infer the population level statistics, because in the epidemiology modeling, we need the population scale to understand or to infer the case better. So this is why we based on the active mobile devices ratio in each of the region, and then based on the observed mobile phone tract flow, and to extrapolate the population level data. And we also compare with two well-known spatial interaction models. One is a gravity model, which models the undirected linkage between two places. Another is a directed radiation model. And those two models are well-known models in modeling human mobility patterns. And for the gravity model, we need the fate parameter, the K, and then the distance decay beta, because gravity assumes that the interaction between two places is in proportion to the attraction or population size of the origin destination, and in reverse proportion to the distance between the two places. So for the radiation model, there is no such parameter turning process needed. However, we do need to know what are the ratio of the people are moving. So this is why we can also get the ratio of the people are moving based on the mobile phone devices, because as you can see earlier, at different times, different portion of people in different places, they moved. So there is a spatial heterogeneity there. We need also capture this. But overall, the observed data has some high correlation with the radiation model predicts. So as expected, because the radiation model, as we know, capture better for the directed flow network, and also good for the longer distance travel modeling versus gravity, which is better for the city level or the metropolitan level modeling. So lastly, we utilize the mobility model into the actual epidemic modeling. So we develop a new SEIR style compartment model by considering the inflow and outflow of the mobility. And this is the ordinary differential equation system, and this is by collaboration with other faculties in mathematics, and we can further utilize several most advanced parameter turning technique to turn the parameter and do the diffusion simulation. And this is a state level. And just one quick conclusion derived from this model, and by simulate spatial temporal spread, one thing we notice that is the effect of timely quarantine and social distance mandates. So here in the axis, we show that the delay of the time, for the tested positive and then the exposed people. If we delay the quarantine time in days, and we can see that the susceptible people will be reduced significantly. So which means that really the timely testing and quarantine is very important. This is why right now in many universities, they actually are increasing the frequency of testing, because not only the quantity, the frequency is also important. And we also did for the educational purpose, for training different domain students, we also developed a dashboard to show the spatial temporal simulation with different parameter setting for the model we proposed. And we also did this not only at a national level, as well as a local level. So we slightly modified the model again for the local model, but share the same idea to incorporate the mobility flow. So some takeaway, I think that mobile phone data can help track mobility pattern and also digital contact tracing. But we have the position accuracy issue, also need a privacy consideration. And for the health and social disparity, which is a definitely important topic in geography, we need to consider such a social demographic factors in the different regions. And really, to fighting against COVID-19, we need a large coordination efforts and working with different expertise. So that's all. Thank you for your attention.
All right. Thank you very much, Song. Very interesting presentation. So the audience is encouraged to ask questions. You can do so either by raising your hand or posting it in the Q&A functionality here in the Zoom webinar. We can either prompt our speakers to answer them directly, or if you write your questions into the Q&A, we hope that our speakers can answer the questions maybe after the conclusion of all the presentations, or maybe later on. So I personally have one question, a quick question for Song, which is about reliability and the quality of the data. Can you comment on maybe the different data sources that you use, whether are they trustable, and is there any potential for distrust, which I have heard at different stages from the media. So is there any comment on the data reliability?
Yeah, thank you, Alex. Do you mean the epidemiological data or the mobility data?
I'm personally most interested in the mobility data.
Oh, I see. Yeah. Yeah, because the accessibility, we don't, or will not be able to compare or different data sources, but we do find some inconsistency regarding such as the travel distance measure between two data sources. And this is why I think if we directly or just use the same index, you may find the inconsistency. So this is why maybe one way to do this job better is to really investigate each source with some maybe common knowledge or at a more local level, and to see whether that makes or met the expectation. And because, for example, looking at the temporal trend, you can see whether, for example, the changes in the stay-at-home order or lockdown period actually meet the expectation. So we do find the inconsistency. So this is why we choose what we think is the best quality in the further modeling effort.
All right, thank you, Song. Maybe just a very quick question from the audience. Yingjie Hu asks, what is the data that you used for calculating the average close context index?
Oh yeah, so this is the same individual level data I showed in the slides about the mapping the north the Daikoha mobility trajectory provided by Xmode, this company.
All right, thank you very much, Song. Very interesting presentation. I would like to move on to our speaker number 2, and this is Soo Yeon Han, and she is from the CyberGIS Center for Advanced Digital and Spatial Studies at the University of Illinois, Urbana-Champaign. The title of her presentation is A CyberGIS Approach to Exploring Neighborhood-Level COVID-19 Vulnerability. All right, Sue, you're up. You may have to unmute. Yep.
Yeah. Sorry, it takes some time to find a mute icon. But,
okay.
Can you hear me okay?
I can hear you. Great. Yeah, thank you.
Okay. So what screen can you see? Can you see the slides on the entire screen?
I can see your screen. Great. Yes.
Okay, thank you so much.
Laser pointer, so you're all set.
Okay. Oops. So thank you for coming to my presentation. So recently I am exploring the disparities, the regional disparities in COVID-19 infection test and death rates between neighborhoods. So I'm going to present my work in terms of this. So before I present my work, so I would like to acknowledge my colleagues who have worked on this project because we really worked as a team together. So in terms of the disparity in COVID-19 infection research, so I have noticed a lot of scholars found that some neighborhoods such as communities of color or economically disadvantaged people are being hit disproportionately hard by COVID-19. But there is very few studies to systematically explore the neighborhood characteristics in relation to COVID-19 outbreaks. And also I found that previous studies have rarely used the GIS approach to identify the location and boundaries of vulnerable neighborhoods to COVID-19. So the objective of this study is to explore disparities in COVID-19 infections, tests, and death rates between neighborhoods and identify vulnerable neighborhoods to COVID-19. So we made a CyberGIS enabled visual analytics system called the Vulnerable Neighborhood Explorer. So using the Vulnerable Neighborhood Explorer, the users can delineate the neighborhood boundaries based on their selection of variables describing socioeconomic and demographic profile. And they can also explore which neighborhood has higher COVID-19 infection, test, confirmed, and fertility rates than another. So in other words, it helps the users to help identify vulnerable neighborhoods to COVID-19 outbreaks. So for the case study, we selected 4 cities, Chicago, New York, Greater Phoenix, and Greater Miami, which from Central, Eastern, Western, and Southern US respectively. So I will cover the methodological approach that we used in this study. So we used an exploratory data analysis approach. So by using the Vulnerable Neighborhood Explorer, I mean, by using the visual analytics system that we made, the users can make on-demand changes to the display and access a variety of linked visualization so that they can explore the data from different perspectives. So through this exploration, Vulnerable Neighborhood Explorer guides users to develop promising a posteriori hypothesis. The thing is that we are not modeling nor predicting. So our methodological approach is exploratory data analysis. So like I mentioned, we wanted to first delineate neighborhoods using socioeconomic and demographic variables, and then explore which neighborhood has higher COVID-19 infection, test, confirmed, and fertility rate than another. So in order to achieve this, we used the K-means clustering to delineate neighborhood boundaries. The neighborhood boundaries are clustering of similar socioeconomic and demographic variables. So we used 18 variables to create a clustering. And we found that the variables that were used to delineate boundaries in previous literatures have commonalities. So we came up with 18 variables that were commonly used in previous studies to delineate neighborhood boundaries. So this is where we downloaded the COVID-19 data. So we downloaded the zip code level data at 4 different cities. So zip code were the smallest geographical unit that are available for COVID-19 data. So this is clustering and also visualization result. So in case of Chicago, in this case, so every time the user creates the neighborhood delineation, the Vulnerable Neighborhood Explorer also automatically creates the chart that visualizes COVID-19 cases, tests, and deaths in its different neighborhood. So A1 is a map of visualizing COVID-19 test rate or death rate or infection rate if they are available. So in this drop-down box, you have an option to change the layers. And A2, A3 are the results from neighborhood delineation. So which is the K-means clustering results of 18 variables, and A3 works as a map legend of A2. And the areas within each cluster are similar to another in terms of neighborhood characteristics, such as demographic and socioeconomic status. And C1, C2, these two charts visualize the mean Z-score of each of the input variables, which can be used to understand the characteristic of each cluster visualized in A2 here. So the bar chart B1, B2, B3 visualize the crude infection rate, test rate, and the confirmed rate in each of the different neighborhoods. So there are 5 different neighborhoods. So now I would like to share with you how we got the clustering, the neighborhood delineation. So I used the elbow method and came up with the 5 cluster as the most appropriate number of clusters. The table here, it has the characteristics of each 5 neighborhood in Cook County in Chicago. The heat map visualization on the top represent the Z score means across clusters. So from this heat map visualization, we were able to identify these characteristics of a neighborhood. So the previous literature also used the mean Z-score to identify the neighborhood characteristics like this using the mean Z-score. So we used the same approach with the previous study. And C1, C2, C3, C3, C4, so they are the different neighborhood types. So for example, like the C0, this neighborhood type are characterized by wide educated, wealthy elders, homeowners, newer and expensive single home, so something like that. And C2 are characterized by white Hispanic foreign-born aging homes and affordable housing costs, and C2 Asian educated renters, and C3 like Hispanic foreign and born and medium poverty, and C4 is black poor, high unemployment rate, vacant homes. So and then to put it more simple, and I made a simple more straightforward labels here. So making this label was also influenced by the previous literature, and the previous scholars in the previous literature, they did the same thing to classify the neighborhood and identify the neighborhood characteristics. So we applied the same process of classifying and labeling neighborhoods in 3 other cities too. So here are the findings in terms of disparity in COVID-19 across neighborhood. So these are the findings. So these are the specific findings that I got from the visualization here. So based on these findings, so my conclusion was that although the COVID-19 is distinctively widespread in like a Hispanic laborer among or different neighborhood types, the test rate in Hispanic laborer is only slightly higher or even less than that of other neighborhoods. So generally, there's a geographic disparity in COVID-19 infection, like as well as the test rate, but the infection rate shows the greater inequality than the testing rate. And this time it shows the COVID-19 confirmed cases by 4 different races in each of the 5 different neighborhoods in Chicago, Cook County. So A1 is the confirmed cases of white, A2 is the confirmed cases of Asians, and A3 is the confirmed cases of Hispanics, and A4 is the confirmed cases of Blacks. So the study area is still the Cook County in Chicago. So here my finding was that in A3, confirmed cases of white is highest in white Hispanic aging or suburban neighborhood. And in A3, the confirmed cases of Hispanic is highest in Hispanic laborer neighborhood. And at A4, the confirmed cases of Black is highest in Black poor neighborhood. So these findings are not surprising at all because in this case, the confirmed cases of Black is highest in the area where the Black population is high, and the situation is same with the confirmed cases of whites at A3 and Hispanics at A1 and Hispanics at A3. But this A2, this chart shows the exceptional pattern. The clusters of confirmed cases of Asians are not located in the neighborhood where the Asian population is clusters. So what A2, this one shows is that even if Asian population is clustered in Asian elite renter neighborhood here, Asians in Asian elite renter is much less vulnerable to COVID-19 than Asians in white Hispanic aging suburban, where the number of Asian population is just around the average. So Asian elite renter, like this neighborhood consists of a much wealthier residents and more college graduate than white Hispanic aging suburban. So maybe it is why Asians in Asian elite renter is much less vulnerable to COVID-19 than those in white Hispanic aging suburban neighborhood. And this 4 chart is the normalized version of the 4 chart that I shared with you in the previous slide. And this time it shows the crude rate of white, Asian, Hispanic, and Black in each of 5 different neighborhoods in Cook County in Chicago. And I found that Asians and Hispanics have the wider disparity in COVID-19 infection between neighborhoods than whites and Blacks. And the findings implies that being Hispanic in white rich owner neighborhood leads to a much lower risk of getting COVID-19 than being Hispanic in other neighborhoods. In other words, Hispanics in Hispanic laborer are the most vulnerable to COVID-19 among all 4 races across all 5 neighborhoods. On the other hand, whites and Asians in Hispanic laborers are not as vulnerable as Hispanics and Blacks in the same neighborhood. So this is how I explored the disparity in COVID-19 using the visual analytics system that I created. So I explored the data in a pretty much similar way in other studies areas too, such as New York, Phoenix, and Miami. But I don't think I can cover everything because I'm running out of my time. But just one thing that I'd like to highlight in New York, in case of New York, is that white elite renter, this sky blue, is neighboring with Hispanics with Hispanic poor in Bronx. The crude infection rate in white elite renter is slightly lower than that of it is significantly lower than that of Hispanic poor. So there's a clear distinction between the crude infection rate between this neighborhood, this white elite neighborhood, and the Hispanic poor neighborhood. So on the other hand, like severe outbreaks of COVID-19 in Black owner, like in this neighborhood, occurred in North Bronx, which is very close to Hispanic poor. So here, the fact is that people in white elite renter are much wealthier, and also the education level is much higher than any other neighborhood in New York City. So these findings implies that the spread of COVID-19 in Hispanic poor affects the spread of COVID-19 in Black poor, or vice versa if they are neighboring each other. But even if white elite renter neighborhood is located close to the Hispanic poor neighborhood, the severe outbreak in Hispanic poor is not likely to result in an outbreak in white elite renter. And also, one major finding across the four US cities is that the community of Hispanics are being disproportionately affected by COVID-19. The current infection rate of COVID-19 is highest in Hispanic laborers in Chicago and Greater Phoenix, and Hispanic laborer in Greater Miami. The Hispanic poor in New York City is the second highest, but the difference between the highest and the second highest is not really significant. So simply put, in every city, the current infection rate of COVID-19 is significantly high in the neighborhood where Hispanics dominantly reside. So the neighborhood Hispanics which are represented in pink are largely characterized by low to medium poverty rate, low education level, or then inexpensive rental housings. Also in this neighborhood, the percentage of population in the manufacturing and service industry is also above average. So in addition, the percentage of foreign born is far above the average in the neighborhood of Hispanics in Chicago, Phoenix, and Miami. So I have shared the visualization result, and the visualization result that I shared can be created from Vulnerable Neighborhood Explorer. So Vulnerable Neighborhood Explorer runs in CyberGIS X. So they are the parameters that you need to set up to run a Vulnerable Neighborhood Explorer. So I'm not going to go over the details of the parameters, but one thing that I'd like to cover is that the user can enter their own data set. So the number of clusters, clustering method, and also the variable names and what chart they are going to visualize with the maps. So VNE provides an environment where users can create the neighborhood boundaries based on the selection of variables and identify vulnerable neighborhoods to a particular disease such as COVID-19, cancer, diabetes, or disastrous events such as a hurricane or earthquake. So this process requires an exploratory process. I mean, the users need to create a different number of clusters with the different parameters, multiple times until they find a vulnerable neighborhood. Like for example, like users probably want to use more health-related variables such as the percentage of people with the health insurance, or percentage of people commuting by walk, or percentage of people using public transportation to find a vulnerable neighborhood for chronic disease. Or in another case, they probably want to use variables such as the number of mobile homes with several socioeconomic and demographic variables to create the vulnerable neighborhoods to hurricanes. So also, so in some cases, creating like a wider neighborhood is more appropriate than the small unit of the neighborhood. So to figure this out, users also need to delineate the neighborhood boundaries multiple times by entering the different number of clusters. Like in this situation, like easily accessible, reproducible, and scalable geospatial analytics environment is important, and the CyberGIS X environment provides this environment. So there are some limitations of this study. So as you might have already known, the result can be different if we use the different clustering method other than K-means. Actually, I tried several different spatial clustering methods, such as affinity propagation or word or Gaussian mixture. So the clustering results are not likely like a totally different. So it is just a little bit different. Anyway, it affected the vulnerable neighborhood that we identified based on the clustering result. But the major finding was pretty much similar. I also tried the spatial clustering method to create the vulnerable neighborhood boundaries. So in this case, our results were really different. So I think it is because the spatial clustering method forces the polygons to be adjacent to each other. So when you use the spatial clustering method, the far away areas cannot be my neighborhood, even if attributes are similar to another. So I think it is why my result is really different when I use the spatial clustering method. So like I said, the result of this study should not be interpreted as something that you can use to predict the COVID-19 outbreaks in the future. So instead, it helps the users to explore data in many different perspectives, and it also helps users to develop the promising a posteriori hypothesis. So I think I have covered pretty much everything, and thank you so much.
Thank you so much, Sue. Very interesting presentation. While there's no question from the chat, I have a quick observation or a question I'd like you to comment really quickly. I saw your selection of cities for which you performed the analysis was, I think it was New York, Chicago, Phoenix, and one more. So what made you choose these areas? Because I observed they're all like urban areas, right? And is there a limitation, or is there, can you comment on, is it possible to conduct your analysis for, let's say, more rural places?
Oh, yeah, actually, it really depends on the data availability. So I started collecting the data like 3 months ago, and around that time, actually, it was pretty difficult to find like many COVID-19 related data. And I just tried my best to collect the data as many as I can. And then like these are like the 4 cities, they are located in the geographically different location in the eastern, western and southern and like northern US, something like that. So it's mostly because of the data availability.
All right. Thank you so much, Sue. I believe there is another question for you in the Q&A, which I ask you to answer like either in writing or after our last presentation. We got to move on. So thank you so much, Sue. And yeah, I would like to hand things over to our third presenter. Okay.
Okay, thank you so much. Let me stop here.
Thank you, Sue. All right. So I'm very excited to announce our third speaker today, who is Frank Curriero. He's affiliated with the Spatial Science for Public Health Center at Johns Hopkins School of Public Health. The presentation title is COVID Control, a Johns Hopkins University Study. Frank, you're up.
Okay, thank you, Alex, and thank you for the invitation. Thank you for the previous 2 speakers for sharing some of their very interesting work. So I'm going to talk to you about one of the responses we had at the Spatial Science Center here to combat the pandemic, and we're calling it COVID Control, a Johns Hopkins University study, because it was an IRB sanctioned study. I just want to start off and just explain what syndromic surveillance is, because people might have heard that term, but may not have their finger on what that actually means. But it's surveillance. So it's something we're doing to monitor a phenomenon. In this case, we're going to monitor the COVID-19 pandemic, and we monitor it from afar, in a sense. We're going to surveil or monitor indicators of the disease, and as opposed to confirmed cases and so forth. And one very popular indicator, especially in infectious disease, is symptoms. Okay, so what we're going to do is monitor symptoms of COVID-19 in real time or near real time, in hopes to detect potential clusters that may arise, potential confirmed clusters of COVID-19. And our COVID control study is a syndromic surveillance system working on symptoms, based on symptoms of COVID-19. And people have seen these symptoms before. They're very similar to ILI, influenza-like illness. So that term has been around for a while, and we see that some of the COVID-19 symptoms are very similar to ILI, fever and chills, cough, fatigue, these kind of things. Probably one of the more specific symptoms of COVID-19 is this idea of new loss of taste or smell. And that came out, there were a lot of young kids back in early March and April that were experiencing this. And at the time, it wasn't thought to be a symptom of COVID-19. And it turns out it's one of the more specific symptoms of COVID-19. So we're going to be looking at COVID-like symptoms, CLI, as an indicator to potential outbreaks for the COVID pandemic. What are the current situation and challenges when working in this pandemic? Obviously there's a lack of vaccine or efficient treatment for COVID-19. There's lack of effective strategies to predict new disease outbreaks. A lot of people we hear on the news, and we see the Johns Hopkins dashboard, which has generated a lot of popularity. And but we're always told that this is now a hotspot or this is now a cluster, and we're hearing a lot less so about any type of analysis or prediction methods to try to predict what when and where that next outbreak might occur. I mean, we have models that talk about the burden of disease, how many people are going to die, how many people are going to get the disease. And those models are updated pretty regularly, but we see less of models that try to predict these hotspots, so they're in need there. So there's this need for an early detection of cases and new outbreaks. And these symptoms, these systems need to be geographically referenced too. So it's not just, just in the US or something like that. We need to get down to small areas to help with mitigation and control strategies. And then we need this stuff to be sort of real time and continuously updated. So this is sort of was the motivation for building our COVID control study. And as you'll see, it includes both an app, a phone app, as well as a set of analysis. And we're hoping, we're still in the middle of this thing, that hoping it really touches along the spectrum of what we need in terms of prediction, prevention, detection, response, and control for the COVID-19 pandemic. So our approach here, so we built an app, and I'll show you some screenshots of that app, both on the Android and the iOS systems. And this is so that people can anonymously enter the self-reported body temperatures and other COVID-like symptoms. And I showed those on the previous slide. And then we're going to take that data and apply some spatial science analytics to identify anomalous areas, anomalous clusters of high self-reported either body temperatures and or COVID-like symptoms, in hopes to generate real-time risk estimates of where a potential outbreak might be. Okay, so all this is done preclinical, and back when we started this study, the motivation was people were getting tested. Not everybody, unfortunately, was able to get a test if they wanted a test back in March, April, and May, and even June, I think. But it was taking a long time for those results to get back. So if we could have some of this data, this syndrome or this symptom data, weeks before, like a week or 2 weeks before, and then we could hopefully use that data to predict where a next outbreak might come. So again, preclinical, no need for personal information. People are only updating their symptoms. We get this information in real time, and it's continuously updated. Okay, and the idea is to identify these priority high-risk areas. And just like a lot of COVID research now, a dashboard, we generated a dashboard to visualize the results. I think dashboards are going to be here to stay now, moving forward in anything we do in spatial analysis. You see a map over there on the right-hand side. This is actually taken from our data set. And this is just showing you counties highlighted in red that had symptoms of COVID since October 1, so this month. There's 227 counties identified. I'm not showing you how many in each county had symptoms, but it's just an example of the type of data that we'll be using and be working with. But our ultimate goal here is to be an identifier, to signal COVID-19 outbreaks, okay? So where we're seeing a lot of red on the map, is that an indicator of an emerging COVID cluster, maybe a week or week and a half down the road? And hopefully these things can be used to inform health policy, control mitigation strategies, and even de-escalation strategies. So here's just some screenshots of the app. And again, it's available both on Android and the iOS systems. Okay, it's very simple to do. I mean, you download the app. There's a profile that just asks you for your gender and your age. And then it has links to our dashboard and to our website. But basically, you just input the system. So there's a scroll bar for inputting your body temperature. And you take these temperatures with your own thermometer. And then you would put these in, and then there is some toggle questions down there. You can see about inputting the different COVID-like symptoms. You know, so breathing difficulty, headache, loss of taste and smell, cough, and so forth. Just give you an example of the data flow. You know, so one thing neat about this project, it was not just part of geographers or spatial statisticians. It was really a mix of three schools at Hopkins. It's the Bloomberg School of Public Health. So this is where we had our geographers or our spatial analysts and so forth, but also included the School of Engineering, which helped with the app design and also the data flow, which I'll talk about here in a minute. But we also had folks from the School of Medicine as well to sort of ground us into what is needed for COVID. So we had an MD that was right on the front lines of COVID treatment. So we have the app, you know, moving left to right. We have the app, you know, the data from that app is annually picked up and stored in an SQL database. And then we had some R scripts running on that data. One of the primary scripts was to just get the data ready to map, right? So it got the data ready to analyze in a sense, and it outputted these CSV files, which went to Arc Pro, and then it went to ArcGIS Online, you know, to help build the dashboard, you know, feature layer, web map, and then we get the updated dashboard. And everything was updated on a daily basis. Also involved in that R script was software to run cluster detection or hotspot detection. People might be familiar with SATscan, and that's a software we chose to run this, and I'll talk a little bit about SATscan in a few slides, but it basically is looking for those areas where there's anomalous activity of fevers and or COVID-like symptoms. Sort of in the interest of time, I'm not going to talk too much about this slide, but people can go back to it and on the recording and pick it up. And it's just giving a little bit more details about that previous slide as we move left to right in terms of the data flow and what R packages we use in Python scripts and so forth. But it is updated every day at 6 o'clock in the morning, which is nice for what we need in this pandemic. Like I said, we have a dashboard. Here is an example of our dashboard. Okay, it's just the United States right now. It's at the county level. What you're showing on the map here is just the total number of our entries. So we have over 129,000 entries. We have about 9,205, I think, last count, unique users of the app. And I'll talk a little bit at the end about how we really need to increase that number. But again, just like with any dashboard, you can start picking and choosing different areas. You know, we show some summary statistics about how many for each symptom and so forth. And there's an actual website I'll give the link to at the end that you can go to where this dashboard is embedded in and talks a little bit more about our project. So in terms of the spatial science analytics, so this was what's called a cluster detection or hotspot detection method. And I just show you an example here of that same map again. And the idea is to, like, if we highlighted Southern Florida there and say, okay, is this a hotspot? Is that set of contiguous counties, is that anomalous enough of getting this behavior of fevers and or other COVID-like symptoms to be identified statistically as an outlier, in a sense, a spatial outlier or a hotspot. So we have the county symptom map, which is updated daily. The entire US map is scanned for clusters, and this is what the SATscan software does for us. And symptom activity is analyzed in all sets of contiguous counties. So if we're looking for clusters or hotspots, we look at either a county by itself or the counties around it in space, okay, and then we go back in time. okay, also to look for clusters as well. So it's not just an area, but it's an area with a time component attached to it. And StatScan is based on statistical likelihood methods, sort of to be more objective in terms of evaluating what's an anomalous area. In this case, we're using case control data, so it's a Bernoulli model for those who are familiar with StatScan, and StatScan also allows us to assess the significance or p-value. Sort of the concept behind StatScan, and we're using it what's called in a prospective approach here, is like, so today is Friday, right? So if we had some cases in an area, whether a county, whether you define that area as a county or a collection of counties, but if we had some cases of fevers, people with fevers today in this area, that may not be anomalous enough. But if you go back to yesterday, okay, and say, well, I also had some yesterday, and I had some the day before too on Wednesday, then you say, okay, well, listen, Wednesday, Thursday, and Friday, if I look at that time period in this area, this set of counties that I'm looking at, that together is anomalous. Okay, so that's sort of what we talk about, a prospective space-time cluster detection. Okay, and so StatScan determines if the number of symptoms in that defined area, like I just explained, both in space and time, is greater than what we would have expected under some null hypothesis. And that null hypothesis is that the cases are not clustered. Okay, and we use these statistical probability models, for example, in this case, the Bernoulli model, to help us identify what's anomalous or what's not. Okay, and we actually have the dots on the map. So when people input their body temperature, the phone records their location. So we have their latitude and longitude coordinates. Okay, so we do have the red and blue dots on the map, red being it is a fever and or symptom, and blue is nothing, every day. Okay, so we analyze it at that dot level, at that point level, but then aggregate the results up either to the county or even to the census tract level. And then like I said, statistical likelihood methods are used to gauge how anomalous that discrepancy is between the observed and the expected counts. And then StatScan uses some Monte Carlo simulation methods to assess the significance and get a p-value for clusters. So we can report significant clusters, or in this case, even clusters that are borderline significance. And again, in the sense that they are identifying a leading edge of a potential COVID-19 cluster in the days and or week to come. Some current and future work with this study is we really need to increase our numbers, okay? Because although we have 9,000 unique users across the US, that really isn't that much when you consider that space, that size of that space. And so we really don't have the power yet for a StatScan to identify clusters that will help enable to identify an emerging COVID cluster. So we're really looking to promote the app and user engagement, and we're looking at collaboration with other institutions and other efforts that are now being used to track the COVID pandemic. You know, with the vaccine coming out, we're also trying to think about, is there some way we can help with, you know, targeted vaccine use? We want to improve the current analytical methods. So, you know, incorporating data from external sources. So maybe looking at positivity rates or hospitalizations, and can these also be used to help identify some leading edge of a COVID cluster, and some new algorithms, and bring in machine learning and so forth. A big point here is validation. Okay, so we can do this work, but what we really need to do is we really need to compare our symptom clusters to the COVID clusters. And are we really seeing symptom clusters in some time, days and or weeks before a COVID cluster? And that's when we have enough users, when we have the power to do that, then that's when I think the app will really become a prominent feature in helping combat the COVID-19 pandemic. And maybe we should also consider other COVID outcomes. So it's not just cases, maybe it's deaths or hospitalizations, like I mentioned, and so forth. So we're in a mix of doing all this work and hoping to get some internal funding from Hopkins to really go at promoting the app and advertising it and so forth. Because everything now has been our own grassroots efforts to advertise and get user engagement in the app. Just to close here, you know, the COVID control, it's easy to use, it's fast, widely accessible to everybody. You know, we get county and census tract level results. The data are aggregated to analyze regional trends. Individual data are protected, obviously. So users' privacy is guaranteed. These are anonymous submissions with the option to deny the automatic access to their locations. And if they do that, then we just ask for their zip code. Some observational exploratory process. So again, we're finding indicators of what's happening today. And are those indicators enabling us to say what's going to happen in the days and or weeks down the line? And even tapping this idea, this study with other processes, contact tracing, lab testing, and these kind of stuff, I think can really help us further along in the pandemic. But like I said, validation is key. So we're hoping to get enough users of the app so we have enough power to identify these symptom clusters and then show how they relate to COVID clusters down the road. And like I said, a really unique part of this study is that it's a collaborative effort across 3 schools at Hopkins, the Bloomberg School of Public Health, the Whiting School of Engineering, and the School of Medicine. And I just wanted to highlight the rest of that group, so you see myself and then Drs. Ralph Etienne Cummings and Dr. Robert Stevens, were the PIs of this grant. And then the students and the analysts that fall under us, although we are the PIs, it's the students that are really the workhorse behind a lot of this. And so I just wanted to make sure I highlighted and showed their names and pictures. And then down in the bottom left, you see the website for our COVID control study. So you can go to that website. It talks about how to download the app and so forth, and has links to our dashboard. So I will stop there, hopefully in enough time. Thank you.
Okay, Frank, thank you so much for this very interesting presentation. You also generated some interest here in the Q&A and chat functionalities of this webinar. So I'm just going to read 1 or 2 questions for you from the Q&A. The first one is coming from Max Camacho, who asks whether there is any collaboration with local health departments to look at syndromic data directly from contact tracing / case data sets. Yeah,
we tried. Okay, no, there isn't, but we tried and we continue to try. One of the things, working on COVID-19 is difficult. I mean, not only is it something that's happening right now, right? So we all have to respond right now, but trying to get a hold of anybody for collaboration assistance is really challenging because we're all so busy. And this is even with Hopkins, who has direct connections to the city and the state health departments and so forth. We talked to CDC a couple times. That didn't pan out with anything, but I think once we're able to show that this actually works, that syndromic surveillance, looking at symptoms can identify COVID outcomes in the day and or week ahead, then I think we'll be in a lot better position to see collaboration. But what we've tried, but haven't been totally successful on that. Thanks for the question.
All right. So I may read you another question, which goes by Bin Lin, who asks you how to consider geographical bias of the symptom data. So can you speak towards biases in the data that's reported from the app?
Yeah, so there's several sources of bias, okay, and I won't ask specifically which one you're looking at, but obviously this is self-reported data, and with any self-reported data, you're going to have biases, and there may be biases in the thermometers that people use, obviously, whether it's the oral thermometer or the electronic ones we see. Again, this speaks to the need to have enough people, okay, to have enough power so those biases don't affect the analysis too much, but they're always going to be there. There's also spatial bias. I mean, if you look at the map of where we have most of the users, it's around Baltimore. Well, that's good. We are, and that's, it was a grassroots effort for us to advertise and promote the app. So we reached out to everybody we know, and our friends, and that obviously is going to be concentrated geographically around where we are. So yeah, so there are several sources of bias. In terms of the going back to self-reported bias, if we have, if we have repeated people, if we have repeated inputs to the app on a daily basis, which is what we hope to have, we can control for those bias because we can measure those bias within a person. So if a person has, you know, if a person is putting their temperature and COVID-like symptoms in on a daily basis, we have their time series of data. So so we can measure and account for those self-reported biases. But yeah, that's a great question though, and certainly a limitation that we're up against.
All right, Frank, thank you so much. I would like to thank all of our three speakers of today and would give them a round of applause. Yeah, the cyber infrastructure, a specialty group of the AAG is very happy and thankful for your contributions. We're very happy and thankful for all the people that attended, who are interested in research on COVID-19. Let me see. I have another bunch of questions in the Q&A session, which if all of you have time to stick around, I'd be happy to ask. Let's see. Yeah, so maybe again for Frank, you mentioned that you don't have enough users, right? And then one of the questions in the Q&A is, Dr. Curriero, how many users do you need to reach the reliable conclusion, and how frequent do users need to report? Yeah,
I get that question a lot, okay, and I've yet to come up with a really good answer for it. It's more than we have right now. This is not something that there's a simple power calculation that I can just plug and chug and give you the answer to that, but it will be based on simulation, and it will be based on how well we're able to identify, how good we are at validating, you know, with real life COVID data and COVID clusters. We have a lot of data, more data for the Baltimore area, the Maryland and Baltimore area. Again, that's just because of the bias in terms of our users. We've done some preliminary analysis with the data just from like Baltimore City and Baltimore County, where we do have good spatial coverage of people, and we do have some promising results, but we're still not there yet to be able to say that we validate this approach. But that's a great question, and I apologize for not having a better answer for it.
All right, thank you, Frank. This may be an opportunity to express my own curiosity. So maybe to all of our panelists, the response in the United States to this pandemic, I personally don't see it's a success story. But can you report some success stories of your own research on COVID-19? Has your research, reached audiences and informed audiences that were you able to make a difference? It is something I always like to ask, and sometimes the answer is no. Sometimes the research, the conclusions of the research, is not what people want to hear. So if you have any anecdotes on that, I'd be very thrilled if you could share them.
I guess my mic is still live, so I guess I'll answer first if everyone's okay with that. In terms of success stories with this, it's pretty clear we're not there yet with this research, but there's a company out there called Kinsa, K-I-N-S-A, who has and had before the pandemic. They did this with flu. They have what they call a smart thermometer. So it's a thermometer you buy from them, about $100, and it's Bluetooth linked to your phone. Okay, so it's very easy. You don't need to update the data. You just take your temperature, and it's automatically updated into their app. And they use this for flu. Okay, we had some conversations with them very early on, back in early March, when we first were coming up with this idea, and they seemed to be doing similar things. And one of the differences between them and us is that you didn't have to buy one of their thermometers. You can just use your own thermometer at home and also input other other symptoms. We had several conversations with them. We never wound up collaborating, but I'd like to think that our efforts and what we were trying to do pushed them to do more of what they're trying to do. So a small success, not necessarily, you know, our own personal success, but it pushes that idea out there in terms of science to try to get people moving in this direction and building these type of systems to help with the pandemic.
All right, thank you, Frank.
Yeah, maybe I can speak for the modeling aspect. And I think there is no clear successful story yet, I think, because as one comment, I think on JAMA was saying that all models are wrong, but some models are useful. So I think that why was saying that one aspect is that if you look at the using the compartment model prediction, it all will go into the same trend. You know, if you're using the presetting parameters or even using the calibrated parameter at the beginning, but you know, the situation will change because human behavior change, right? So this is why we never know, you know, what we are going to, you know, to go unless what we can do is only based on, you know, different policy or different social distancing guidance or testing frequency, testing capacity that can be modeled in the different models, and then to reflect what would be different, right? So, but only if those you know, those interventions can be implemented successfully, then we can see the actual, you know, actual situation will be the same as the modeling. Otherwise, it will always, you know, diverge. So I think there is a gap, obviously, yeah, between our research outcome and with the public communication, and then also linking to even just the support decision making, because we are not the decision maker, we are just supporting them, right? So to give more you know, different scenarios and then more rich information to support them. Yeah, I think that's our role as an academic researcher.
All right, thank you. I see, Sue, you have another question in the chat. So somebody seems to be interested in your CyberGIS system. So that's already a success story. Yeah, I'd like to ask you to get back to these people. Okay.
Yeah. Yes, I'm answering the question.
All right. Well, yeah. Again, the Cyberinfrastructure Specialty Group of the AAG likes to thank our speakers and our audience for sticking around and for offering their views. Maybe to conclude this webinar, I just want to mention that this webinar has been recorded and it will be available as a video on our website. Again, the web address is in the chat and in the Q&A of this webinar. You will see it. Yes, please go ahead and you know, you can, if you missed us, then you can see this video again. So yes, and please look out for the cyber infrastructure presentations and the sessions at the upcoming AAG meeting in April 7 to April 11. Thank you very much. And with that, I conclude this webinar. Thank you.
Thank you, Alex.
Thank you, Alex. Thank you, everyone. Bye-bye.
Bye.
Bye. Thank you, Alex, for organizing this. He left.
Oh yeah, yeah,
yeah.
yeah.
No, I just wanted to say thank you because it's my first time to see you, maybe, right?
Right. We
Yeah.
we haven't consciously met. So
yeah, but I read your paper, the Saskan one. So I enjoyed reading it.
Oh, thank you, thank you.
So I'll be watching your work.
Yes.
Okay,
yes,
thank you so much.
Yes, in turn, I will look out for your publications. It's always good to stay informed and to get new ideas. So yeah, thank you for saying that.
Yeah, thank you. Bye.
All right, take care.